Okay, good morning, everybody. My name is Mike Persenaire. I'm one of the neurologists at the Alzheimer's Disease Research Center. So the topic I'm going to talk about today is one specific kind of dementia, and that is vascular dementia and how it relates to indigenous populations of North America. So first, I want to make the point that vascular dementia matters not just because it is one of the forms of dementia, which is an abundant cause of suffering, but it is one of the major contributors to cognitive change, even rising to the level of dementia in older populations. Also, it's highly associated with modifiable risk factors. So risk factors for this particular disease that we have some degree of control over with the technologies we have available to us at present. And close that. I just got a battery low sign. There are several points of contact between with this topic and indigenous populations. Some of the things I tried to discover were, is the prevalence of vascular dementia different in this population? Are there any particular challenges in measuring what the prevalence might be for this population? How about differences in risk factors? Both, are there unique risk factors that are not seen in other populations, or are is the prevalence of the vascular risk factors that we already know about different in these populations? If we had answers to those questions, would there still be differences in access to treatments for those conditions, or even awareness in the community? These are the points that I want to cover today. I'm not going to go through these in any detail. First of all, what do we know about prevalence of vascular dementia in the U.S. population? This is information that comes from the annual Facts and Figures report put up by the Alzheimer's Disease Association. So we know that 40% of brains of individuals that have dementia from any cause, so they meet this criteria of change in their cognitive abilities, rising to a level where they are not able to complete all of their normal activities of daily living. 40% of those individuals will have evidence of cerebral vascular disease as a component of the pathologic change. So they could have other things seen by a pathologist as well, including Alzheimer's disease. It's only a small number of individuals that will meet that criteria for dementia and have solely cerebral vascular disease. Many people that have the pathological changes of Alzheimer's disease also have evidence of cerebral vascular disease. So Alzheimer's disease and cerebral vascular disease, I'm going to make the point several times in the course of this talk, are pretty intimately related. We also know that the prevalence of all-cause dementia differs. This is not specifically vascular dementia for this point. Prevalence of all-cause dementia does differ by race in the United States population, with African Americans about 2 times as likely to develop Alzheimer's disease or other dementias, whereas Hispanics are about 1.5 times more likely compared to the racial group self-identifying as white. And then you have this little blurb taken directly from that report where they hypothesize that there are differences in the prevalence of risk factors for Alzheimer's disease, and maybe that's why there's difference in prevalence of dementia. And I think there's actually some evidence that that may not be the whole story. What about prevalence for indigenous populations? Well, the prevalence of vascular dementia for indigenous populations in North America is not known. I looked pretty hard for that. So did some of my colleagues. We could not come up with a specific number. We do know that all-cause dementia is different. And here you have the relative prevalences. So the American Indian, Alaskan Native, 22.2 per 1,000 individuals. You can compare that to white and Asian Americans, which have rates that are significantly lower. There is information known, the bottom point on this slide, there is information known about indigenous populations outside of North America, in Australia, for instance. When that group is looked at, the indigenous population will have a higher prevalence of dementia. But when you look at the specific subtypes of dementia, it's not all that different than the general population. So if you take dementia as a whole and you break it up into a pie chart, which section is Alzheimer's disease, which section is Lewy body, which section is vascular, it's going to depend to some degree on whether or not that's a pathological study. So if you're basing that assessment on actual autopsies versus meeting some kind of diagnostic criteria, the pie chart would look actually somewhat similar between those two populations of people, with one caveat. They must have similar life expectancies. Individuals that have significantly lower life expectancies will have different kinds of relative contributions to their cognitive impairment. I want to switch gears and get into the pathobiology of vascular cognitive impairment and start talking about the clinical symptoms, how this disease is caused, how it progresses. So we're talking about vascular. This is blood flow to the brain. It's brought to your brain by arteries and then drained from your brain by a system of sinuses and veins. And many people think about arteries as just conduits for flow of blood to the brain. That is not at all the case. The microenvironment known as the neurovascular unit, the smallest blood vessels in combination with their neurons, there is a very complex and intricate control mechanism to get the blood to the parts of the brain that need it the most and also get metabolic waste out of the brain. For instance, we know that, or consider these facts. The brain is just 2% of body weight, but uses 20% of the body's energy. That energy use is highly dependent on which parts of the cerebral cortex or big populations of neurons called ganglia within the central nervous system are active in any particular task. So the brain needs an ability to shunt blood from one place to the next with a really rapid response. And that's what this neurovascular unit is going to be able to do. It's going to respond to metabolic signals to glean information about what parts of the brain are currently being active, which will dilate blood vessels and allow more blood to those parts of the cortex. So if this system is damaged, if the microenvironment is damaged, you're going to have loss of that signaling intricacy. I talked about the waste removal component to the neurovascular unit. Most of the rest of your body has what are called lymphatic vessels, where metabolic waste can be drained through. They're not arteries or veins, these other tubes that can drain them to lymph nodes and then dump them into the venous circulatory system. The brain doesn't have that, so the brain needs to rely on spaces around blood vessels and spaces made by neurons and non-neuronal cells called glia, so cells of the brain, to wash cerebrospinal fluid in and then wash metabolic waste back out towards the blood vessels. So if there's vascular damage or blood vessel damage, that can also impair that pathway. The neurovascular unit is also really important for regulating your immune system access to your central nervous system. And that is done by what is called the blood-brain barrier. So there's a connection between neuroimmunology and cerebrovascular health. On the bottom here, you can see a diagram of the neurovascular unit. These kind of orange blobs with the darker orange center, those would be muscles. That's what your vessels are going to use to control the diameter of the vessel. And by controlling the diameter of the vessel, you can change the amount of blood flow to any particular part of the brain. These green areas on top of that, those are part of a cell called an astrocyte. You actually have more astrocytes than you do neurons, which are the cells that we think of as doing the thinking. Those wrap their little feet around these blood vessels and help to control that microenvironment. At the top, I think this is a pretty good time to just point out that these blood vessels on diagram A there, On diagram A, the large blood vessels form what is called the circle of Willis. So if you have a complete circle of Willis, you see how all these blood vessels are kind of connected. If there's a blockage in one of those areas, blood can actually still make its way around to the other blood vessels just by taking the other route. Here is a picture of what some of these larger blood vessels would look like. So over here, if you put dye in these blood vessels, what you see are the larger blood vessels here. The very small blood vessels will only show up as sort of a white smoke. The point is, you have a lot of blood vessels in your brain, really complex branching patterns. Over here on this side, you see the vascular territory. So each one of these larger blood vessels has a name. For instance, the lenticulostriae arteries, for instance, LSA. So what you're seeing here is for each larger blood vessel, you're seeing the area of the brain that it is responsible for carrying blood to. This is important for the neurologist to know about because the area of the brain, the clinical syndrome, the symptoms that an individual might experience are going to be based on what part of the brain is damaged. So you can have a set of symptoms that indicate what part of the brain is damaged, and then we can tell what vascular distribution that has taken place in. That gives us a handle on what kind of a vascular injury is this. Is this a blockage in one of these bigger vessels, or is this a bunch of different kind of little blockages in smaller blood vessels? If you zoom in on the blood vessels, you can see that we're talking about blood vessel damage, but that doesn't come in just one flavor. There are all kinds of different blood vessel ways that a blood vessel can be damaged. Down here you can see in these large arteries, these are the carotid arteries. These are main pathways that bring blood from the heart, which would be down here, up to the circle of Willis, and then it's distributed throughout the rest of the arteries. You can have blockages down there that decrease blood flow to the brain. You can actually completely block one of these off, and that would reduce blood flow to the brain, but you can still get adequate blood flow through the other side. If you look at very small blood vessels, there's all kinds of different changes that might take place. And I'm not going to go into the details of what these changes are. The point is, there's not going to be one fix for preventing vascular cognitive impairment. We're going to need to understand the details of how each of these works and what risk factors are associated with each in order to cut down on the entire burden of vascular cognitive impairment. Draw your attention up here to this part. This is the CAA, that stands for Cerebral Amyloidangiopathy, and you'll hear the word amyloid come up over and over again when talking about Alzheimer's disease. The same form of amyloid is sometimes responsible for this pathologic process where that amyloid, that protein, gets jammed in and around the blood vessel walls, causing them to weaken so that they can rupture much more easily. I'll show you some pictures of that in just a second. A bit of a historical perspective here. On this timeline, it kind of starts where you see Alzheimer kind of let the world know that hey, when folks are having difficulty with their behavior or thinking, it's not necessarily a mental illness. It's not a psychiatric disease necessarily. He pointed out that there are these pathologic findings that are closely associated with that. Prior to this, most people were thinking that these changes, if not psychiatric disease, had something to do with blood flow. So there's kind of a pendulum swing where it's, the thought was this is mostly vascular cognitive impairment as the explanation for these issues. Then Alzheimer started to produce evidence that there was actually something else going on here. And then there is a ton of information learned from the 60s right on to the present about how these changes of Alzheimer's disease take place. In the mix of that, vascular contributions got lost in the mix to some degree. Is my take on it. I wasn't around when all that stuff was going on. But these two guys, all the way back in the 70s, they were starting to say, hey, when you look at these cognitive changes in elderly people, it's not Alzheimer's. It's not all Alzheimer's disease. There's more to the story than that. So I want to introduce some concepts, and the point of this slide is that there's an umbrella term that is used, vascular cognitive impairment. What that means is changes in cognitive abilities from baseline. Doesn't say anything about the severity of it. And it also doesn't, there's no information in this concept of vascular cognitive impairment about the specific cause of the vascular injury. So this is all cause. This could be blood vessels broke open and caused bleeding, or blood vessels were clogged off and caused lack of blood flow, or cerebral amyloidangiopathy would be wrapped up in there as well. If you want at the next level information, you can add kind of severity ratings. So here, vascular dementia would be changes in cognitive function that we believe are due to a vascular cause or contributed to by a vascular cause, and they're severe enough to cause impairments in activities of daily living. That is what vascular dementia specifically means. There's all kinds of different criteria that are used. There's a huge overlap in these, but they all get at basically the same thing. And just like for Alzheimer's disease with the mild cognitive impairment stage, that's where there are cognitive changes that are still pretty mild. People are able to do most of their activities of daily living still. And here the concept of vascular mild cognitive impairment just indicates that that MCI state doesn't appear to be driven by Alzheimer's disease pathology. It's a non-Alzheimer's disease pathology. And when you have evidence that people are having small strokes, or even on a picture of their brain with an MRI, you see that there has been cerebral vascular damage. Those individuals would be said to have vascular mild cognitive impairment. And when an individual with mild cognitive impairment and evidence of Alzheimer's disease pathology is present, there is in virtually every case going to be progression of that process if that individual lives long enough. With vascular mild cognitive impairment, I conceive of that as a real opportunity to make some interventions to try and stall that process out. There still is, in the majority of cases, progression of that process, but if we can get a hold of if we can understand what's driving that process, if there are modifiable features or factors there, then we really want to put the pedal to the metal and control things like blood pressure, diabetes. In Alzheimer's disease, you can describe a couple of characteristics, or more than a couple, characteristic syndromes. And that is because there are certain kinds of brain cells in certain parts of the brain which are more vulnerable to the changes of Alzheimer's disease at its earliest phases. So in the typical kinds of Alzheimer's disease, you see people that are very forgetful. It's mostly a memory problem initially, before language and some other things get started. The same can't be said for vascular cognitive impairment, because every single part of the brain depends on a blood supply for its normal function. So if you have a vascular injury to the part of the brain where the motor output of language is being handled, then you're going to have some speaking difficulty. But you could have a change there. Also, along with the part of the brain that allows you to move your right arm effectively. So you could have some motor deficits along with some language deficits. And really, vascular cognitive impairment could impair any function that the brain is in charge of mediating. The vascular cognitive impairment subtypes can be organized into these different kinds of categories, where in the top left corner you see that even a single large infarct, so one of the bigger blood vessels is blocked, you could have dementia following that. Number two, if you had a global reduction in blood flow to the entire brain. There are certain parts of the brain which have a higher risk blood flow, where if you had like a cardiac arrest or in the course of a surgery you had really low blood pressures for an extended period of time, those parts of the brain might suffer the effects of loss of nutrients or oxygen supply. Number three, there's something called cerebral small vessel disease. Number one's talking about the big blood vessels here, and number three, we have these very small blood vessels, and that is it's damage to those vessels when you see something called the Binswager's disease, which I'll show you a picture of in just a second. The cerebral small vessel disease causes a different kind of syndrome. When I say syndrome, I mean a collection of symptoms that somebody would have. So it's distinct from the single or multiple cortical infarcts. And then number four, you have, you may not have a ton of cerebral small vascular disease, although number four is a form of blockage in small blood vessels. But if you get some very small strokes in just the right parts of the brain, you can get a pretty profound dementia syndrome without one of these gigantic strokes. So I want to show you just some pictures of MRIs for each of these vascular cognitive impairment subtypes. So remember before I showed you that multicolored image of each of the vascular territories. So here on the left you see an individual that's had a stroke in the anterior cerebral artery causing damage to the frontal lobe. In the middle cerebral artery causing damage to the left temporal parietal lobe, and on the right, an infarct in the posterior cerebral artery. I won't go into the details of what each of these syndromes cause. It's fascinating. It really gives you some insight into what kinds of functions each of these parts of the brain are handling. This would be an example of somebody who's had a global reduction of blood flow. These areas right here are the border. These are another depiction of the vascular territories. This would be the middle cerebral artery, anterior and posterior cerebral artery. The border zones between them are called watershed zones. The blood supply here is at higher risk. So when you have a global reduction in blood flow, you can have damage to these, vascular damage to these areas. So this is somebody that had a global reduction in blood flow, and they had some vascular damage that shows up on MRI. This would be taking the form of kind of an acute watershed stroke between the middle and anterior cerebral artery. An example here of the watershed between the MCA and PCA. When we talked about the small vessel kinds of vascular cognitive impairment, that's further divided into two categories called the lacunar stroke. Lacunar is a stroke. The reason it's called a lacunar is because lacunar means lake. So you get these very small, kind of well-demarcated circles where there's a blockage of a very, very small blood vessel. And you can have a lacunar stroke. If it's in the right spot, there may not be too many symptoms, so it's not too uncommon that you would do an MRI in an individual and you would see evidence that they've had a lacunar stroke, but they had no idea that that had ever taken place. There was no change in their experience at the time that the stroke had occurred. Whereas with other lacunar strokes, you could have a person suddenly unable to move the left side of their body, say, or difficulty with speaking or difficulty with moving their eyes. So the lacunar state means that you just have a number of these lacunar strokes or lacunar infarcts in just the right spot, building up, culminating in vascular cognitive impairment. And then in the Binswager's disease, you have changes also in very small blood vessels. There's not necessarily a lot of lacunar stroke, so it's not that you can see a single blood vessel that had closed off and caused an area of ischemic damage, but there seems to be a global reduction of blood flow in many of these small blood vessels. Maybe some of them are actually closed off, maybe some of them are not. And so what you see on an MRI is a lot of the white matter and deep structures just take on this white appearance on a FLAIR image. You don't need to know what a FLAIR image is for now. But that means that tissue, if you did an autopsy on this individual, that tissue would appear abnormal under the microscope. It doesn't tell you a thing about whether or not there are functional neuronal elements running through those parts of the brain. So I have definitely come across individuals who have mild cognitive problems, but they're still, involved in their orchestra and doing all kinds of complicated things, but they've noticed a change in the way their brain works. And when you meet somebody like that, you do want to have a picture of their brain to make sure that there's not something, not only to make sure that there's not something that needs to have quick action or an intervention on, but also to help you get some idea of what the specific cause of that cognitive change is. You do an MRI in that situation. Sometimes you see quite a bit of this kind of cerebral vascular damage without as much dysfunction as you would have expected. Whereas in other cases, you see just a little bit of this and the person is unable to take care of themselves at age 65. And you wonder about the disconnect between there. I think some of it has to do with MRIs they're not measures of function, they're just measures of molecular tissue change. But I also think that when you have these kinds of vascular pathologies, that is often not the sole cause of the vascular or the cognitive impairment. There may be a number of other pathologies in the mix there if you had the brain to look at under a microscope that the MRI just doesn't show you. You must use clues from your clinical history and the other aspects of the brain MRI, the specific volumes of different structures to help make that judgment. Here it would be an example of some areas of the brain where if you did have a stroke, there's a greater likelihood that will be associated with cognitive impairment. The caudate, the lenticular nucleus, and the thalamus are all examples of collections of neuronal cell bodies that lie not out here in the cortex, but in deeper structures called ganglia. And then, so if these structures are all involved in processing of information and in allowing the person to interact with their environment and so on. So it's not the cortex is very important for thinking and cognitive function, but so are these structures down here. And then an image of what is called cerebral amyloidangiopathy. So that's where that amyloid protein can get lodged in and around blood vessel walls and cause them to become weakened. And if you get a special kind of MRI sequence that looks for ferromagnetic material, you can see that there are depositions of that kind of material here. And when you see that distribution, you think this must be coming from a blood vessel. And when they're far out by the cortex like this, the most likely cause is that this individual has a cerebral amyloid angiopathy. What's happening here is those blood vessels are breaking open and leaving little stains of some components of blood, the hemosiderin. To what extent do these little kind of micro bleeding events impact cognitive function? It's tough to say, but what's usually going on in a person like this is that same cerebral amyloid angiopathy is not only causing bleeding events, but is also causing some of that a very small blood vessel change. So it's also contributing to reduction in blood flow to the deeper parts of the brain. I started by talking about the close relationship between cerebral vascular disease and Alzheimer's disease. And we went through some of the numbers about who has what specific molecular changes. What we know from big studies where people are followed for decades and then autopsies are done at the end of their life, and you can ask the question, well, between the people that seem to age without having any cognitive problems and those that had mild cognitive impairment or dementia, what do you see in their brains? By far and away, the most common cause would be what we call mixed dementia. So there's more than one pathological change taking place. But there's a big overlap between individuals that would have Alzheimer's disease and these cerebrovascular changes. Alzheimer's disease and vascular cognitive impairment are also connected to each other by their many risk factors that they have in common. So diabetes, blood pressure, especially high blood pressure, especially in midlife, increase the risk for for vascular cognitive impairment and Alzheimer's disease. So there's a relationship there. There are differences between the kinds of symptoms that these two entities cause. We just went through a number of the potential syndromes of vascular cognitive impairment. In general, though, in the vascular cognitive impairment syndrome, there's a greater degree of executive dysfunction early on in the process. Executive function is actually a number of sub-functions like working memory, ability to sustain attention or selectively move attention from one task or another. And that is largely mediated by the frontal lobes, which have a big demand on blood supply. There's more frequently slowed processing speed. A lot of the vascular cognitive impairment takes place in the connections between these neuronal cell bodies, between the cortex and the basal ganglia. So it can damage the transfer of that information processing. Dr. Hansen talked about amnesia and what that means. Amnesia is a certain kind of memory loss. These individuals, if their syndrome is driven primarily by vascular damage, they often have a memory retrieval deficit. So that part of the brain that allows them to learn new information and retain it, that's not necessarily impaired. When they fail to remember something accurately, if you give them hints or clues, you can often trigger the memory to be recalled. So that's just showing you that the information was actually learned and in some way instantiated in the brain, but they can't retrieve it very well. That is important for therapeutic reasons. How can you improve somebody's life? Alzheimer's disease should not be affecting your ability to walk and use your arms or sensory function in the early, the first many years of that process. Whereas vascular cognitive impairment, it could absolutely start with a stroke that impairs the ability to walk or speak or sensory function on any part of the body, or vision for that matter. If you compare groups with vascular cognitive impairment and Alzheimer's disease, what you find is that changes in mood are common in both groups, but somewhat more common in the vascular cognitive impairment group. And then when trying to differentiate between what is the true cause of a dementia syndrome, you can catch on to this when people are explaining to you a stepwise decline in the individual at question. So if they are going along just fine and they seem to have kind of a rapid drop-off in their cognitive abilities, maybe a period of stability or even improvement, but not quite back to baseline, and then there's another rapid drop-off. So they kind of follow this stepwise pattern. You can't assume that those are all strokes or vascular events. It could be something like a seizure as well, but in many cases they will be. And then when you do a brain MRI, lo and behold, you do see a lot of vascular change. So this stepwise decline feature in the history is incorporated into a lot of diagnostic criteria schemes. This is information from one of the larger clinical pathologic cohorts. So clinical pathologic means what kinds of symptoms did the individual have, what were their cognitive performances like, who were they demographically, and then at the time of autopsy, what did you see in their brains? Even Alzheimer's disease rarely occurs in isolation. And Alzheimer's disease, again, very frequently associated with vascular pathology. In these larger studies, this one comes from the religious orders study. They tried to determine how much of these different pathological changes is contributing to somebody's overall cognitive performance? And what they found was that the changes of Alzheimer's disease, Lewy body, and then something called hippocampal sclerosis, which is a different kind of pathologic change altogether. They're pretty potent influencers of cognitive function. The changes of vascular disease were actually somewhat less potent influencers of the overall cognitive performance. The next couple of slides are about how would you go about determining if you had an individual that met the criteria for dementia without not hinting at a specific cause. If you had an individual with dementia and then they had say Alzheimer's disease and also vascular cognitive impairment, how would you go about deciding, well, what was the main driver of that? Was it all Alzheimer's disease, or was it half and half, or was it mostly vascular? That could be important once we have some way of fixing damage that has already been done or halting a pathologic process. If it's all Alzheimer's disease and only a smidgen of vascular cognitive impairment, the effort should be focused on stopping the Alzheimer's disease pathologic process. Or the opposite could also be true. What this study found was that when people had Alzheimer's disease pathologic changes, they were only really doing worse than you would have expected when they had infections to the cerebral cortex or in the deep gray structures, the caudate and lenticular lenticular nucleus and thalamus. In this study, they showed something very similar, but they also showed that there is a synergistic relationship between these things. So having the changes of Alzheimer's disease is bad, but having Alzheimer's disease and vascular cognitive impairment is actually worse than just the summation of those two things in isolation, or what you would expect if you just summed the two processes in isolation. It may not have actually been this study, but it's also known that early on in the early changes of Alzheimer's disease, vascular damage is often contributing to a greater extent than when Alzheimer's disease starts to progress. Then Alzheimer's disease kind of takes over and is the major contributor to cognitive dysfunction or the dementia syndrome. I want to spend a minute talking about the genetics of vascular dementia. And this really will be just a minute. Not much is known here. But vascular dementia, it's thought to be like almost anything else, a matter of genes and environment interacting. But because of the risk factors associated with it, there's a hefty bit of this can be modified by changes in comorbidities. So in your environment and how you live your life makes a big difference. But just how heritable is it? There are some rare disorders where if you inherit a single gene, you are going to experience the consequences of vascular damage. When you look at the kind of sporadic vascular cognitive impairment, so not inheriting a single gene, but some of these genetic risk factors, it's actually not too easy to find those. You can find a number of genes that are associated with stroke, which is associated with vascular cognitive impairment, but not with vascular dementia itself. And this gene up here, the ApoE4 type allele, is associated with vascular dementia, but the risk of that is not nearly as high as it would be for the risk of Alzheimer's disease. These are the modifiable risk factors that I think there is compelling information that these are associated with a greater risk of vascular cognitive impairment. So I've explained what vascular cognitive impairment is, how it relates to Alzheimer's disease, and some of the risk factors. And we also know that prevalence of dementia in a lot of populations is there are inequities there. And I think that is probably true of indigenous populations. So why would that be? So here's a few hypotheses. There would be many more. But what kinds of evidence could you look for to support one of these hypotheses? Well, this information about disparity in mortality, or the cause of mortality in these individuals, are highlighted here. So diabetes appears to be more frequent as a contributor to mortality in this population, whereas cerebrovascular disease, for this data set, did not look like it made too much of an impact, even though diabetes would be associated with cerebrovascular disease and a lot of cognitive outcomes. This taken from that same data set. This study looked at not indigenous populations, but differences between the causes of dementia in between populations. And what they showed was that there are differences in risk factors for these things. There are differences in demographics, what percentage of that population is smoking. But if you control for all these things, there's still a big amount of, a difference in prevalence of dementia that still needs to be explained. And that looked like, if you controlled for factors associated with socioeconomic status, that if you added that into the model, then you could explain the entire difference in prevalence of dementia. Just to summarize the connection between this topic and indigenous populations, I've made a number of these points already. It does look like some of the risk factors are more prevalent in this population. It's maybe not the case that, it may be the case that if you just take the entire set of people that have dementia, that the rates or incidence of Alzheimer's disease or vascular or Lewy body may not be all that different than the entire population. But we still don't know still don't have any specific knowledge about vascular dementia in indigenous populations. We'll wrap up talking about ways of preventing vascular cognitive impairment. So you want to modify what is modifiable. So look at that list of risk factors. There could be interventions with nutrition. I have supplements on there. That's actually there's not too much high quality information that any particular supplement would help, but the diet seems to make a difference. Certainly control of blood pressure, atrial fibrillation, smoking, diabetes, stroke, and high cholesterol makes a big difference. And then there's these early life interventions around educational attainment, intellectual activity, which build conceivably something like cognitive reserve, so your brain's ability to take a lot of damage and still function normally. This is a picture from a big study that was done looking at all studies relevant to this topic to date, and they estimated that maybe up to 1/3 of the causes of dementia. It's a little small, so I'll point out what's going on here. So they looked at all the risk factors for all-cause dementia, and there's genetics up here, things that you could do early on in life, things that you could intervene on in midlife, and then things that you could intervene on at any point in life. And some of those are going to be non-modifiable. So we don't have technologies currently to impact these, but these would be potentially modifiable. So without any new discoveries, you could really take a chunk out of all-cause dementia. We're going to run a little bit short on time, so I'll be fairly short with these slides. But there is information that interventions targeted at diet and exercise can make a difference even later on in life. So that's what the finger study showed. It was a multi-domain intervention, diet, exercise, and cognitive training, and really good control of vascular risk factors. And they did show that there was some improvement in some cognitive outcomes. Same can be said when looking specifically at the nutrition. So in the PREDIMED study, that was a randomized controlled trial looking at the Mediterranean diet versus a control diet. And here again, there was some improvement in the cognitive function of individuals in the intervention diet. And this is uncontroversial that control of specific vascular risk factors like blood pressure can not only reduce the risk of stroke, That is almost certainly the case. But in the second study, the CIST-YUR study, showed that by controlling blood pressure, you can actually decrease the risk of dementia, at least in this randomized control study population. So these studies were done long ago. We don't do randomized controlled studies in blood pressure because it is so clearly beneficial to one's health to have blood pressure controlled. So these are just the graphs associated with each of these studies. I'll belabor those points. I'll just leave these summary points up for you to read and open it up for questions.